Okay.
You're good.
Thank you. Thank you all for coming, especially on Friday at the last day. So we're really excited. We had a little bit of a change in plan here. So I'm very excited to talk about this and excited that my esteemed colleagues are here with me. We are going to talk today about innovations and pharmacological approaches to the treating alcohol and opiate use disorder. And as you all know, more than really 1 in 11 ED patients are related to substance use. Some of us who work evenings or nights or whatever think that it's the entire ED that's there. We have effective treatments, and we know that for some reason they are lagging in use, and they can be very, very effective, and they are really cost effective as well. So we're here to kind of amplify our efforts to make sure that, again, we can save a lot of lives by talking to you about medications that you could initiate in this really important touch point as patients are in the emergency department. All of our presenters here today are really experienced clinicians as well as addiction specialists and researchers. So I'm excited to tell you about them. We have no disclosures that we're going to tell you. We have Dr. Ryan McCormick is a punt presenter with us today. And he is going to help us out here because Dr. Hawk had an emergency this morning and had to leave early, but all of us do not have any. There are pharmaceutical companies that may have provided medication for something, and Alchemies had provided medication for his study of naltrexone, but none of us have any interference with with those companies, just as though we will be talking to you about the 7-day injectable of Brixadi. It was provided to us to NIDA, and NIDA provided it to us. We have no interaction with the companies. So I'm going to quickly just go over some of the people that are here, and then we will go. Dr. Andrew Herring, who really needs no introduction here, as a professor at UCSF, works at Highland and is a director of research there. He is the primary PI of California Bridge, which we know is the most exciting, really government and state-run intervention and strategy for patients with opiate use disorder. And he is not only boarded in addiction and emergency medicine, but also in pain. And we're very excited to have him here. And we're going to go on to Ryan. Dr. McCormick will be next. Dr. McCormick is associate professor at NYU. He has done many things. His initial K was on the use of naltrexone in patients at Bellevue. I was lucky to be one of his mentors during that time. He's been funded for screening intervention for opiate use disorder for patients that are in rural and really under-resourced emergency departments, and we're really happy to have him here. He will be talking to you about medications for alcohol use disorder. And last but not least, Dr. Jimmy Prim, who I'm sure all of you know, who's not only boarded in addiction and emergency medicine, but also in toxicology. He's going to talk about some implementation strategies that we have here. And Jean Marie has been really instrumental in her, not only in her university and city and state and the world, in talking about opiate prescribing. All of these investigators are part of ED Innovation, looking at the 7-day injectable. So I'm going to stop right there and let you go first.
Thanks, everyone. It's great to be here, and we have such a small group, so I feel like we should definitely jump in as we move along. Okay, so this is, we'll just get going with this slide. We've all seen this slide many times, but there's probably some fatigue, but it is meaningful, I think, for stakeholders and ourselves just to remember, how massive this is, and how persistent it is, and how unusual it is literally in human history. So to have a population of our size exposed to this much opioid with this much death due to opioid is a rather, it just hasn't happened before. Maybe China was the only other historical example. And so how do we unwind this knot? Like, how do we land this plane in a humane way? Is this massive moral, ethical, medical, and policy question in front of us. And one of the sort of things I'm worried about is this sort of sense of, one, futility, and two, even more cynically, there are high-level stakeholders who are thinking that this quote will burn itself out. That means the cohort dies, right? Because the cohort of opioid users is going to perpetuate itself, recruit new members, and grow. That's what opioids do. If we don't intervene, change demand, then the options are either to grow or just simply to die. And so there is some creeping cynicism as we get this far into federal funding, this far into the opioid epidemic with very modest or lack of change in the overdose rates. There's an incredible need to keep the drive and passion about this, that this is not something that we can simply stand by and let play out as if we have no agency. We have one thing that we really know works, right? And this is medications. Again, there's a lot of fog. Supervised consumption facilities are not going to fix the opioid epidemic. Prisons are not going to fix the opioid epidemic. Naloxone is not going to fix the opioid epidemic. Naloxone doesn't change demand. It won't change the epidemic. You can't give naloxone to yourself. There's just these fundamental things that we really need to be in front of stakeholders in your community, in your hospital, just to point out these obvious things, that the thing we know that will change, if you model out how can we change predicted deaths, it's MOUD, it's methadone and buprenorphine, that's it. And that's where we should just be really focused on this radical center of get buprenorphine or methadone to as many people as possible, as conveniently and quickly as possible. And that is just the rational approach to what was in front of us. So buprenorphine is this incredible, unique medication that thankfully we are seeing some innovation, right? There's very little innovation in general within drug development around substance use disorders. This is a bright spot where people have come together to create these long-acting products. So what does this mean? This is just simply a formulation. It's either Atrogel or liquid crystal, depending on Braeburn or Indivior, and it's a little syrup, right, that goes into your body, underneath the skin, into the subcu fat, forms a little husk, like a gobstopper, like a lozenge, and then gradually just dissolves over time. The wonderful thing about developing this was it really pushed people to think about what is the appropriate dose of buprenorphine, as opposed to just being kind of stuck with 8 milligrams, 16 milligrams, 24 milligrams. People like Mark Greenwald said, well, okay, at what level of plasma concentrations of buprenorphine do people start making more self-interested, rational choices to, for example, take a money reward versus take an injection of hydromorphone? And really trying to be more rational. And I think that's a real future state for where we're all going in the field, is how do we tailor and the architecture of these treatments to target craving in very specific ways, so people are choosing to avoid drug or are protected from overdose if they receive fentanyl, things like that. So these drugs do represent kind of our first generation of these sort of rationally designed drugs that are targeting specific levels of buprenorphine in the blood. The one that we've been working with this incredible team here is Brixadi. This is approved here now in the United States. It's got a wide variety of formulations, and its basic pharmacokinetics are, the sublingual is very rapid, right? Sublingual comes on very quickly. It then is washed out fairly quickly with this long tail.
It does have a clicker.
Oh, thanks. Okay, great. Oh, perfect. With the long tail. The pharmacodynamics are a little different, and so the sublingual will persist and bound receptors longer than that graph looks like here. So it's not quite as extreme a drop-off as that looks like in terms of how the effect on people is. Then the Brixadi has a slower rise over the initial 24 hours, peaks, and then it's going to have this long tail. The rate of this rise is really dependent on how much drug you're giving. So if you're using 16 milligrams of Brixadi, it's going to have that slope. If you're going to be giving 158 milligrams, it'll have a little bit of a steeper slope. So the lower the dose, the lower the slope there for the long-acting injectable. The release of, as I mentioned, the volumes or the doses range. They target the sublingual doses, 8 to 10, 12 to 16, 18 to 24, with these various extended release doses. That's very much approximate, right, as we see, because the PK curves are so different. You really can't, they're apples and oranges. It's a very different experience. One sublingual, where you're having peaks and valleys in the first week particularly, until you achieve a steady state. Whereas with the XR is this nice, steady, smooth flow, which is very anecdotal, but we feel that people tend to like this experience. It's more consistent and preferred by many patients. We have seen that in this paper, very specifically looking at our folks that are part of an ongoing RCT that's almost done, over 1,900 patients now recruited, beginning with 25 or 28 sites, and now coming down to the end. We've just wanted to get it out into the world, the basic experiences that patients are having with Brixadi. It's very positive. The take-home is people tend to really like it. You can imagine fears of, having a doctor put a needle into my belly. It's more intimate. It's more vulnerable. People might not like it. There certainly are those people, but in general, it's very well received. And it's just a convenient there's a certain feeling of miracle where you're just like, oh my God, I don't have to go to the pharmacy. I don't have to use drug. It has this real honeymoon effect where people really, really like it. It's very consistent. So the incidence of precipitated withdrawal in our trial has been very low. This is a big trial. We are looking at folks all over the country, from out here in the West Coast to fentanyl hotspots on the East Coast. And here you can see the red dots or the red stars of precipitated withdrawals from the sublingual, and then the blue are from the XR bup. Now we've only had a total of 14, and we're up to 1,900 patients. So it's still less than 1%. The real thing to understand here is that part of the way a clinical trial works is there's a certain slowness to it, and there's a certain methodicalness to it, right? So you're being identified, you're being enrolled, you're being consented, and just sort of the wheels of justice move slowly, right? In the same way, slowing down clinical practice, it does mean that the general judgment on what is the state of withdrawal, when was the last time of use, is going to be better, right? Than in this sort of fast-paced, real world of clinical environment. I say that just because there are folks who say, this is crazy. No way. You've got a precipitated withdrawal rate of less than 2%. That's just completely made up. That can't be right. Well, I think that probably has to do with just the structure of trials, which does sort of suggest that in clinical practice, if you are methodical, if you are careful, and you sort of go through the steps in an organized way, you too will probably have a similar rate of precipitated withdrawal. Whereas in the sort of real world of practice, people might not be as careful there. That's just a guess. What the take home is that it's very rare. And this is not like we've been doing this for a short amount of time with a small number of people. This is a lot of people over every part of the country. The characteristics, so the folks folks we've enrolled, and then the folks with precipitated withdrawal, there's really very little to distinguish them. Fentanyl in the folks who did not have precipitated withdrawal was very prevalent at 75%, so we're not selecting for non-fentanyl users. And their other drugs are also common, methamphetamine, cocaine, etc. These are all the individual cases of folks with precipitated withdrawal, and it is interesting. You can see that the baseline count is quite varied. Some of the folks are quite low, like right on the border there, 7, 8, 5. Then other folks were quite high, 29. So the other folks were quite high. There was some unpredictability there in terms of who had precipitated withdrawal at this low prevalence. When you move out into practice, so I was going to say, where's my other slide? Okay, we'll go back there. So now switching gears a little bit, that was XR, so extended release. Now the other, for folks if you don't have extended release, one of the options is the higher dose method. And this is something that in California in particular, and really in many places where we are really trying to get a lot of people treated. So in the California Bridge program, we have treated about over 100,000 visits in California with buprenorphine. And the older method of 4 + 4 just was not working. It just wasn't working. It was too slow. It was too miserable watching people get half treated. So we just have really moved, and it's quite, we weren't completely sure if this was going to be the right way, but it's turned out to be the right way. So for folks who are in withdrawal, in California, we generally start with 16, 24 or higher. And that just kind of powers through these little micro early withdrawals and gets them to that feeling of feeling good. The role of positive emotion in early initiation of buprenorphine is a really big deal. These sort of cross or slower, lower dose initiations where you never actually feel good, you just kind of feel crummy, almost, but not terrible, do not bind people to treatment. So we've been using high dose for quite a while. This was where we kind of got started at a single site here in California, my site, over 500 encounters, 5 cases of precipitated withdrawal that was not dose related. There were no incidents of precipitated withdrawal, of desaturations, respiratory depression, things like that. It was quite safe. The length of stay was short. That's why our PAs and general team love it, because you get them you're not messing around with multiple doses, get them a nice big dose and they feel good and they go home. In clinical practice, spreading it out to, we've gone to 270 hospitals in California. This study, looking very closely at 6, we found similar results with a very low incidence of precipitated withdrawal. Same thing. So very quickly, just moving on, you should all know that the 3-day rule has changed, so now you can dispense methadone. It's very tricky to dispense methadone from the ER, but it's possible. You just got to do a lot of tango with your state pharmacy and your local pharmacy and unwinding all these intersecting regulations that have not been updated to be synchronized with the DEA. They will get there. This does bring up the possibility of prescribing cross tapers where you can prescribe an agonist and buprenorphine. So there's interesting things to come. But so you should just know that that's here. They also allow for a little bit of a higher dose of 50 milligrams, which will not always, but often be very low for many folks out in the world. But nevertheless, that's great to see that rise. With that, I want to pass the baton. Sorry, I had to sort of speed up through the end there. We'll have time to chat.
So just moving on to alcohol, one of the positive outcomes of the opioid epidemic is that it has ushered in kind of this paradigm shift of treating substance use disorder, including alcohol use disorder in the emergency department. There's been a lot of momentum of also addressing alcohol, which I don't really need to tell you that it's common. We see more alcohol than we're going to see with opioids and most other substance use. It's costly, and it really wreaks havoc on the individual and society. And the rates of problems related to excessive drinking are continuing to rise. The good news is there are treatments. The pharmacological treatments are not as effective as the treatments for opioid use disorder that we're also talking about, but they are effective, and some people really have a robust response to them. There are only a few, it's only been studied to a limited extent in the emergency department, but the medications have been around for a while, including this first slide is a protocol that was implemented, and it was a single-arm retrospective study where they introduced a protocol and looked at the outcomes of almost 60 patients, both getting oral or the injectable, and the follow-up rates. We were able to show that they were able to show it was feasible and able to follow up with some of the patients. And it's just in the emergency department setting. Then in another study where they randomized patients, I'm sorry, this was not randomized. It was a single-arm study, open pilot in California also, where patients were given 3 injections of extended-release naltrexone plus care management. And they also showed that this was not like a pure, like feasible but there was some efficacy to this, that with care management extra and really harnessing the resources, it was acceptable. And they were able to see from pre-post that the drinking outcomes went down, and the quality of life benefits were demonstrated, even though it was a relatively small sample, or a small sample. Very recently, there was a study of Medicaid patients discharged from the hospital, and those that were received treatment for alcohol use disorder had reduced an absolute reduction in hospital utilization. There are other studies that have also shown that starting medications reduce healthcare utilization, or acute healthcare utilization at least. There are 3 approved medications. There's naltrexone, which is in an oral and injectable formulation, acamprosate, which is an oral formulation, and disulfiram. Both acamprosate and naltrexone can be given in someone who's still actively using alcohol. Acamprosate has been, kind of, when you look at the nuance of the benefits, acamprosate is, its benefit is shown in people who have already achieved abstinence before starting it. And disulfiram is aversive, so that makes you sick if you're drinking. So that is not something that's not something I would necessarily that we would typically use in the emergency department. The benefits, kind of the difference between them, from a adherence standpoint, the injectable naltrexone is it's a 30-day injection, and when taken every day, the oral naltrexone has a similar efficacy, but the problem with that is adherence. Acamprosate is 3 times a day, so that's an even bigger jump for adherence. So for those reasons, I think that focusing on naltrexone makes the most sense. You can take them while drinking. They reduce craving, both when drinking and so when you're drinking, it helps you drink less, and also in between drinking helps you reduce the craving to drink. And so these are some of those meta-analyses. Acamprosate showed reductions in abstinence. Again, those were people who had already started with abstinence. And then naltrexone reduced heavy drinking and cravings. I've already discussed some of this. So naltrexone, there's the oral and the injectable formulation. Adherence is the big issue. Naltrexone is an antagonist to the opioid receptor, so you want to make sure that a person is not physically dependent on opioids. If they use opioids, not for like 10 days. One thing you can do, particularly because there's so much fentanyl in the cocaine supply, you can have somebody give a naloxone nasal spray beforehand if you want to confirm that. Another thing is, if you suspect somebody's in acute liver failure, or if they have LFTs greater than 5 times the upper limit, it's contraindicated. I've already talked about acamprosate. And gabapentin is not FDA approved for alcohol use disorder, but it has a kind of a complicated pharmacology, mostly through the glutamine and GABA effects. It's efficacious and safe. It has minimal effects on alcohol withdrawal, so it does not prevent seizures, and severe alcohol shouldn't be used as monotherapy for severe alcohol withdrawal. You can give it off-label. It has been given and tolerated at high doses, starting quickly. It does cause some dizziness and somnolence sometimes. The patients that we're talking about are used to having pretty high doses of GABAergic effects, and they tolerate it well. And there's a Cochrane review that showed no high risk or serious side effects. It does help it helps in a lot of different ways, and also kind of like what I call like the B symptoms. So like maybe not the acute alcohol withdrawal, but like kind of mood and sleep and insomnia and how you feel. And I really find that people tolerate that well. And since that's 3 times a day, that might be, that helps with, wouldn't be a bad mix with acamprosate, but you can give it with any of the previous medicines that we've talked about. This is kind of what Kate and Gail are doing through a study, and there's protocols that exist. And the one that I would probably recommend is going to the Bridge to Treatment website. There's some really nice resources there. We got started a little late with some of the mix-up, so I'm going to just try to be real quick so that you have time for questions. Thanks.
Stand here. You just got to do that off the fly. That's pretty cool.
Thanks, Ryan. Thanks, everybody, for sticking with us. So essentially, there are these maybe 4 or 5 medications that we can start to use in the emergency department, but you need to make it easy for clinicians to do this. And there's so many, many, many steps that what I've learned from my implementation colleagues is that you have to make it easy and you have to make it right at the point where you're identifying a patient who could be eligible. So I'm going to talk a little bit about some electronic medical record interventions that we have done to enhance the amount of these medications that we can use in our emergency department. So the first study that we've done, I see we're, so that was basically about the time, and we've been able to evaluate these interventions around the use of treatment of buprenorphine, as well as dispensing naloxone and referring to treatment. So one of the things that we're going to talk about is a paper that we published, which is kind of an overview of how we've done this. And what we were able to demonstrate was that we were able to double the rate of treatment engagement and prescribing of buprenorphine for patients with opioid use disorder. And the way we did this was we actually got consensus from our nurses that we wanted to add a question in triage specifically about whether or not a patient is suffering from opioid use disorder. So we used a single screener question. In the past month, did you use a painkiller, heroin, or fentanyl? You could probably take the heroin out of it these days, but using that, it deployed a cascade of effects, which meant that the nurse identified the patient. If the patient said yes, or the patient was a drug overdose, it directly allowed the nurse, ordered an order for the nurse to assess a COWS, or a clinical opiate withdrawal scale. So the nurse was then put in what the COWS score was, and if the COWS score was elevated enough, greater than 8, it expedited a BPA for best practice alert for the nurse to initiate treatment. It also provided a banner for the clinician to go to an OUD order set, and I'll show you that. And it also notified our peers that there was a patient in the emergency department who had opioid use disorder who was actively eligible for medications. So that whole cascade resulted in the peers helping the patients get to treatment, subsequent follow-up treatment. The nursing BPA and the provider banner together was allowed us to double the rate of opioid prescribing. And the way we know that that worked, not just while we were also prescribing a lot of buprenorphine, was that we deployed the EHR interventions. So you can see that's the banner that the clinician gets, and you can actually click on that to go to the OUD order set. But we actually deployed the ED order sets in 3 of our hospitals, but not the other 3. So we actually had a control for the intervention, and we were able to show, and that's what shows on that red line. So our prescribing maybe was a little bit variable. Then we deployed the order set, and since then, at the initial hospitals that had it deployed, there was a doubling in the rate of buprenorphine initiation, and now we've deployed it at all of our hospitals. So then I want to talk a little bit about a larger clinical trial that was done at 5 health systems across the country. And they sort of did something similar. They used clinical decision support to implement initiation of buprenorphine. They created several tools to help clinicians. They did not find an increase in buprenorphine prescribing yet, but they did actually increase the number of physicians who have prescribed buprenorphine, which is actually a heavy lift, because in a lot of places there are a bunch of clinical champions who believe in this, so that might be like 40% of your hospital, of your ED group. So in this, one of their results was that they actually were able to show that 44% versus 34% in the control setting. So they've created a lot of apps. This app, Bupe Initiation, is actually very helpful. I used it all the time in my emergency department because it allows you to measure a COWS score on your phone. which is sometimes easier than looking up the scale. And it actually scores it for you, which is also nice. And then there's multiple steps in workflow that's enhancing, including beginning an OUD assessment, making ultimately the OUD diagnosis, and then doing that same withdrawal assessment. And then they use clinical decision support to help, if it's a cow's greater than 8, use, 8 milligrams of buprenorphine, greater than 12, use 12. I don't actually know exactly what criteria they used, 4 and 8, I don't know. But we're able to deploy, clinical decision support at the point where clinicians needed it. And then they had order sets, much like ours, and including the buprenorphine prescription, which for a long time was very difficult to prescribe because you had to put your X waiver in, and everybody screwed it up all the time, at least at my setting. So this was pre-filled out, which is actually very helpful. So those are EHR tools. I want to talk about something else that we did around the time of COVID, and I know Andrew Herring has done it as well. SAMHSA has this line that they staff, which is very helpful. I called it and said, I was just discharged from treatment. I live in Pennsylvania. I need to get on buprenorphine. And they said, oh, okay, well, we're going to transfer you to a place nearer to your home. They gave I gave them my zip code, and I talked to a person at a treatment center or treatment referral center, and she said, well, you can come in next Tuesday, and you'll get assessed. And I said, well, I get a buprenorphine prescription that day. No, you'll get an appointment to see a doctor in about 2 or 3 weeks, depending, and you'll get a buprenorphine prescription. So this is what we're supporting. This does not work for people. And so we deployed a Care Connect warm line where patients can call. So we staff with a substance use navigator answering the phone 7 days a week, 9 a.m. to 9 p.m. And if the patient is a good candidate for buprenorphine, they have opioid use disorder, they are seeking treatment, we get them an appointment with our Penn Medicine On Demand urgent care, which is a virtual urgent care that treats coughs and colds. And we trained the nurse practitioners who answered that line. They were very eager to do this work. We're going to get you people who are pre-ready, we're doing all the sort of assessments that you need in our electronic medical record, and then we shuttle it over to them. So within 1 or 2 hours, they're having a telehealth visit with a nurse practitioner who prescribes buprenorphine. And then we pick up the patient again and make sure that they can get to the pharmacy, that they don't get difficulties at the pharmacy, and then we follow them for a couple of weeks, and then we get them into our primary care practices where they can continue buprenorphine. So this is a wonderful program. We've been doing it for about 3 years. It's funded by the Department of Public Health. We can pay for the prescription, we can pay for the telehealth visit, and then we staff our substance use navigators. And we've been able to reach really vulnerable populations, especially in continuing buprenorphine. So 2/3 of our patients are already on buprenorphine. They experienced a lapse, they missed an appointment, they've been suspended from a program, but they want to continue their buprenorphine. And so we fill that gap for them, and then we follow them. We've also been able to reach patients who are post-incarceration. There's a big gap there. Some patients who are getting buprenorphine in jail, are facing gaps when they get out of jail and continuing that. So about 9% of our callers have been incarcerated in the past 30 days. About 15% have been in a treatment facility and were discharged from the treatment facility without a follow-up appointment or without a prescription. So that's, just part of our system failures that we're working on. And about 1 to 2% of them are currently pregnant. So we're really catching these vulnerable patients. We're also looking at follow-up at filling greater than 1 prescription, about 69% of them, and 55% of them have an active prescription at 30 days. So I think this is probably one of the most important components of smoothing out that handoff from the emergency department to primary care and ongoing care. I know Andrew does a lot of this both with a virtual clinic, but also with a walk-in care, and that would be our kind of a gold standard if we could also create an ED walk-in clinic where people could, come back if they're finding other treatment gaps. So despite our challenges, we're ready for some questions with plenty of time. Thank you.
Yeah. Ma'am, on your EPICS, your nursing triage protocol for the 9 single-use question, is that a hard stop at the triage, or can the nurses kind of live by it? Like, when we tried to implement our ESPR programs there, barring the fact that I would not be alive today if I made it a hard stop based on the nursing triage protocol of my operations managers.
Sure.
actually using the screening and how they make sure you're sort of applying?
Yep, it's 100%. It's a hard stop. But the reason we were able to do this is because we got a group of nurses together to decide how they wanted to be more proactive in opioid use disorder. When you look at a group of, people who are between 23 and 35, a lot of younger nurses, all of them have been affected by the opioid epidemic. They all wanted to do more. They've seen patients. They've had family members. They were far more engaged than we might have expected, and they drove a lot of this process. So actually, the only gaps we have is that not every overdose patient gets that triage assessment, because that's sort of done slightly differently. But in triage, it's 100%. It's a hard stop.
Can you talk about how that process and how you work with groups of nurses to come to that?
Yeah. I should acknowledge that, I didn't exactly lead this work. Kit Delgado, who's an implementation scientist, and Maggie Lowenstein, they had a CDC grant that I was on. But what we did was we, asked for volunteers. Oh, and we also had a nurse who presented with us a couple of days ago, Rachel McFadden, who's been working with us for several years. Kind of got who wants to be part of this. There is a triage working group, so we started by working with the triage working group, and yes, they asked 20 questions. They feel most of the triage screening questions are highly irrelevant, and they feel like this one has an intervention that's going to happen in the emergency department, so it's not just screening, but a real intervention, medications. And we started it after we had already built our ED buprenorphine program, so it was really just to optimize the number of people that were able to get to bup treatment. Yep.
Do you know your positivity rate of the screening general population that comes through those EDs?
The general positivity rate, I think it's 4%. I would say that I still know, because we did a lot of other work together, that we were missing people. Many minoritized patients did not feel like they wanted to answer yes, because they are already facing all kinds of battles in getting treatment. So, it's sort of people that we picked up, like my substance use navigators would pick up, but didn't have a positive triage screen, tended to be people who had polysubstance use and just didn't want to admit to that.
I just wanted to add that you could, if you have Epic has all of this embedded in it, and that was it's not based on a screening question. It is a decision tool, so that the clinician, nurse, doctor, APP has to press the button, and a smart set comes up. As the smart set comes up, it tells you everything to do, how to make the assessment, do the CALs, give the medicine. It also then prints out all the information, gives out, then tells you to give you in our institution, we give the Narcan, but it would write a script. It also writes a script for the buprenorphine. It tells you, you manage it with your ED, IT people. It gives you the place to go to, everything, and it writes your note. So as you do that, it writes the note out saying this person has OUD with a CAL score of this. I gave this amount of medicine in the ED. I referred them here. I gave them Narcan and education. So it, one click, right, does the entire thing.
And I think that's 1.3 or 1.4 RVUs to have a note about starting MOUD. So that sometimes that moves the needle in people who are very RVU excited in your groups.
I would just add on that screening always comes up. It's a huge lift to try to do that, and it would not be my primary focus at this stage. We're really trying to get buprenorphine or medications started, and you can start with the low hanging fruit, and then try to move to screen. If you can do screening, great, but it's not where I would focus my attention in first implementing.
Yeah, I would just add to that the yes, screening has this very rational, logical flow. It makes sense, and then some people you approach an ER and you say, oh, we're going to start a new thing that you have to do every single time on this group of people, and they just flip out, right? They hate it. And so one just workaround that we've seen be very effective is, ideally, you'd have you walk in the emergency department and it would say Bupe Depot, right? Or just some big thing. So you're basically projecting out, if you are suffering from this disorder, we have something that you can benefit from right now without question easily. And I really see that as honestly, in many ways, much more respectful and much more patient-centric, because you're acknowledging, why on earth would you, in ever say yes to a screening question on a stigmatizing illegal activity unless you knew that you were going to receive benefit from it. I certainly wouldn't. No way. But if I knew that this ER was committed to giving me buprenorphine or Suboxone, whatever term, right then and there, that's when it's like, yeah, I would offer it up. And so when people offer up that they're looking for help, it also transforms the interaction on the side of the nurse. Because it's very different being like, you know, do you use heroin versus someone being like, hey, you know, I'm struggling. I see that you guys have Suboxone here. Can I get it? It really elicits this sort of empathetic reaction. So I'm a big fan of just public signage that declares what your intent is, which is to, you know, give people buprenorphine right then and there.
Do you have those sites in your waiting room?
Yeah.
And you have templates on,
Yeah,
and there's
go ahead.
templates on the Bridge to Treatment website also. And there's to that end, one, there are clinicians who aren't making this happen, and there are barriers to doing it. But the other is there are a lot of patients are not, or at least going to either refuse or not accept treatment, or it just doesn't happen. And a lot of that has to do, like, there's a lot of reasons and history of why there is no trust, why there's diminished trust between patients and clinicians, particularly this patient population. So that kind of signage and approach does really help that, and that approach.
So they're anti-triage. I'm pretty anti-triage, but I have to say that it really works, and I think it works because there are multiple times where people can identify the patient who has OUD. So there might be, you know, patients are in the ER for 12 hours. So they might have gotten the triage, they might have had a CAL score that's too low, and now many hours later a new team is involved, but they still have the flag, and so they can sort of revisit it, which is actually also very helpful for, you know, our long boarding times, new teams of peers coming in, new navigators. So it does have benefits that I wouldn't have anticipated, and I think whenever you think about screening, if there's an intervention that's going to happen concurrently, that really helps. So we're about to build out the same stuff for alcohol and the nurses are totally on board with adding an alcohol question. So I agree, it's not what I expected, but it seems to be pretty effective.
And we have ours on the initial nursing assessment instead of triage, so that the person that's going to be spending more time with them has that opportunity and has more opportunity, although that misses all the patients that go to fast track because there's a different in a lot of places.
Yeah.
I know the different models you guys talked about using, you know, peer support navigators and certified peer support specialists and everything else like that. Do you guys employ certified peer support specialists as part of your department, or a cooperative relationship with other RCOs in your area that provide peers to provide that bridge to outpatient therapy, you know, in a
Yeah.
health system your way?
Yeah. Our peers are all employed by us, so they have badges, so they can swipe everywhere, so everyone knows their name. They're not a rotating group. I think the other model is much harder to operationalize, especially when they go to multiple hospitals and they don't know the clinicians, and the clinicians don't know them. They don't know the workflow. They don't know, you know, where the charge nurse is. So I really think that it's better, if possible, to have them as your own employees.
Ours are too. We have health promotion advocates. They're not all people with lived experience. Some of them have. They are all people who work in the community, and they are employed by the hospital. And the most important thing is that they're responsible to me and a group that I work with, and that we meet with them every other week and talk about cases. But they can call me 24 hours a day. And a couple of us who are addiction specialists, if they have a question or if a doctor isn't exactly doing what they think they should do. So they'll call me and I'll say, just tell them you talk to me, and if I need to, I'll talk to them. They said, no, if I just tell them that I talked to you, they'll be okay with it. But the important part is there's fidelity to their intervention, right? That they're responsible, that they just don't have an experience of one. They have a collective experience with a lot of people who are treating people, and that they could connect much of the time better with the patient than I might be if, and particularly if I'm rushed in a clinical site. So anything yours are also, right?
We have a mix. We have a big team. We probably have 12 navigators. And so some of them are hired by me as substance use navigators in a job description we created. Some of them are CHWs, community health workers that do the work. And then some are, we have a community-based syringe services program and they're just like super radical harm reductionists that are badged and onboarded and part of the team. So I love that because there's just sort of some cultural stuff that this other CBO can drive into the hospital context. That's really fun. I want to really elevate what Gail said around the role of the clinician with the navigator, in that you're going to see there's a lot of ineffective CHW models where they're just reporting up to a behavioral health person, an LCSW, or no one, and they're completely discoordinated from medical care and understanding how to prioritize something. So one of the sort of hallmarks of what it means, at least in California Bridge, to be a substance use navigator is that you have a dyad, you are connected to a clinician. You are an extender of that clinician. You're really just trying to advance this fidelity that Gail was talking about. And that can get lost because it's a huge component of the model.
Yeah, I would say that peers can also present a very abstinence-based focus in treatment that makes us all crazy. You can find a peers talking, about their journey without medication, and that's not that helpful when we're trying to convince people. So you really have to make sure that they understand the evidence basis, even if they don't need to, share their aspects of their story. But
How do you get that paid for? I mean, my peers now are with grants and other funding agencies, stuff like that, and I'm getting a hard no that we just need social workers and stuff like that. How do you make that gap to your operations to get paid for?
I mean, it's really, so I would say probably most Medicaid programs in the state have some version of recognizing the entrenched fragmentation of American healthcare and understanding like, okay, we just have to pay for this giant set of workarounds. And the navigators are workarounds, right? It's sort of just a way to connect these fragmented healthcare settings. It's going to vary completely by state, but most states will have some either incipient or well-developed community health worker program, transitions of care program. There'll be something like that. And so what you're doing is like you're looking for those big benefits and you're figuring out how to get your navigator to fit into that rubric of what's billable.
Yeah, I showed really how that patients didn't come back within a 1 month period. And I was able to, this was years ago, to present that to the financial committee to say, this is really not a lot of money and we're getting people out of here. We're not admitting them. And the worst thing that can happen in my hospital is to admit somebody, because although we're like the 5th largest hospital in the United States, everyone's in the ED, right? They're boarding, they're crazy. They don't want these individuals in the hospital, right? They're Medicaid or underinsured. They want to do their transplant surgeries. So I showed them that I could keep these individuals out of the hospital if they would let me work with the community, which we are, and these individuals do. We follow them. For 30 days, they have a hotline. They can call in anytime. We avoid them even coming to the ED sometimes. We say, oh, you can just go there right now. You don't need to come here. They'll treat you today. And so we showed that. It's a constant battle, though. I got more of them through another grant, and now I have to keep those up. So I do my I call it my scrapbook attack now. So I've done articles in our newsletter for the hospital. We just did that. March was Alcohol Awareness Month. So we wrote all about the HPAs, pictures of them, how we were able to reduce some admissions, how many people we saw. And then I go to the New Haven Register, and I'm about to do an article, there. So the hospital kind of gets shamed in that way if they don't keep it up, because the community really likes it. I then bring out people. The mayor one day gave me a day that was called Project Assert Day years ago. It's really my scrapbook approach. And so that eventually they feel, Yale isn't really always well respected in the community. They think we just want to experiment on people and that we're not really great. So I go to a lot of meetings in the community. I get them to call people and tell them that you want this to stay. And you sort of have to do that for your hospital, especially in this climate. People don't want to hire anymore, but literally they're really not that expensive. I wish they paid them more, but they see a lot of patients, and the social work model does not work. I can tell you that from doing this in lots of hospitals. They write 3 pages worth of data and do this much work, where our people spend hours getting people places, and they write a note. We have a scripted, it's a soap note. It's 3 sentences, that's it.
We hope to be creating we have approval for trainings for peers so that they actually know how to work in the medical record. They're like, who's an attending, who's a resident, who's an intern, like basic things. So peers get education. I think it's like a 12-week course or something, but we are doing some additional certifications to have peers work in hospitals and have a lot more knowledge about what the hospital-based setting means and, how they can navigate it. So another sort of they're very state-specific certifications, so that's in Pennsylvania, but hopefully that will, disseminate a little bit so you can find more qualified peers, and obviously with that funding and reimbursement for it.
I might just add that even if within the walled garden, so to speak, of a hospital, it can be challenging to sort of articulate the financial benefit of a navigator. It's just important to remember, if you step back, the economic value of a navigator is enormous, right? In the sense that there are many things in medicine for which we don't have effective treatments, right? This is one where number needed to treat is probably like 9 or 10, right? It's really, really effective. And this turns out to be a disorder that not only impacts yourself, right? Your own health, but has this tremendous effect on your economic productivity, your involvement in crime, your participation in as a husband, a wife, a father, of employees. So it's just the economics accrue in a frame that's outside of the hospital. But just sort of you internally should they tell you like, oh, you're just not being hard-nosed enough, you don't get it, it doesn't pay for itself. They're the ones that are wrong. Right, you're right. This actually pays for itself many times over. They just don't get it.
All right, we are at time. Thanks everyone for coming, and reach out to us if you have any questions.